It's my great pleasure to introduce Professor John Hodges. So my first encounter with him was as a young, naive junior doctor when I was encouraged to approach him to do some research. I was in Bristol at the time, and I said, well, shall I send him an email? I said, oh, no, send him a letter. So I sat in on some of his meetings, his research meetings, noted the friendly, open manner he had in association with all of the people that he worked with, and his overwhelming curiosity. I remember with agonizing clarity my interview with him to consider PhD research. I'm sure you'll all know him and his influence on behavioural and cognitive neurology, and indeed, as mentioned earlier, I consider myself lucky to be at least partially Hodges trained. He has authored over 450 papers and several books, including the definitive guide for the bedside cognitive evaluation, particularly for neurologists. He has been Professor of Behavioural Neurology in both Cambridge and Sydney in Australia, and has been the single most important person to develop behavioural and cognitive neurology in the UK, and is well deserved for this year's BMPA Lifetime Achievement Award. Thank you very much.
Just going to put the timer on my phone. Okay, well, thanks very much. And I'm going to talk a bit about the overlap between FTD, which has been a sort of lifetime interest and passion, and the autistic spectrum disorders. I haven't given a talk since pre-COVID, actually, and I've said no to presentations at meetings here, there, and everywhere. But Boyd approached me through Instagram and said, you know, he wanted to make contact, and we talked, and he told me about the sort of, you know, putting together a program on this topic, and so I was lured to do it. And actually, I still have a sort of ongoing research interest with colleagues in Sydney related to this. People wonder what I've been doing in my retirement, or, you know, large retirement. My friends who are here all know that I'm a passionate potter. So I couldn't resist putting some pictures of my pots into the talk. So part one is a brief introduction to FTD. Now, I'm not going to labour this because Chris gave a lovely presentation which outlines some of these features. And this is just a sort of archetypal case that we started seeing in the clinic in Cambridge in the 1990s. At that time, I don't think the kind of concepts of FTD were even very well brought together. There are all these interesting papers about frontal type dementia coming out of Manchester and Lund, and there was progressive aphasia, but it was a very exciting early days of this area. So this is a typical sort of case of a 57-year-old man who didn't think there was anything wrong. His family reported that he'd been behaving inappropriately. It's often the sort of sexual inappropriate approaches that freak the family out the most. He was reported to be emotionally cold, which was a big change, lacking affection, no empathy and interest in the family anymore, making poor judgments with his finances, had become very rigid, needed to eat at the same time every day, craving sweet food, some weight gain, and poor memory. So sort of a full house of symptoms that we now recognize as being characteristic of FTD, which are reported by the family rather than the patient. And in this sort of case, you know, I've shown this is a normal MRI scan through the anterior temporal lobes. So this patient's scan showed clear-cut frontal atrophy, a little bit asymmetric, bit of anterior temporal lobe, scored badly on the ACE, progressed over the next 3 years into care, and died 5 years later. Now, for the cognoscenti of FTD, I've put in a couple of little interesting things here. That it later emerged on further clinic visits and digging into the family history, that he got an aunt who'd been admitted to hospital with psychosis. He got a brother who developed motor neuron disease and a nephew who'd been diagnosed with autism. So that's a sort of typical straightforward case. And we were beginning to see these patients, although we didn't recognize all the symptoms or inquire about them systematically in the 1990s. And as Chris outlined later, many of these features were enshrined into the clinical criteria for FTD. And the ones that I've put in red, I've put these in red because the theme of this talk is going on to the overlap between FTD and autistic spectrum disorder. And of course, the ones in red are also features that are described in ASD as well. And when patients present to the clinic after the publication of the criteria in 2011, 2011, 2012 were very big years in FTD because they were both the criteria that we use and the biggest genetic discovery occurred at the same time. And so since this publication, if somebody presents with 3 or more of these symptoms, but their brain looks normal, we call them possible. If they present with these symptoms, but have clear brain atrophy or PET changes, then we call them probable. And if they have a mutation or have died and have got pathology, then they're definite. Yes, this just shows the very well-established pattern of atrophy in FTD involving the medial frontal lobes, the insula, and the not very well shown because this type of volumetric MRI analysis isn't very good for the anterior temporal lobes, but there's also a lot of anterior temporal lobe atrophy as well. Now, we were seeing people with FTD, and in the 90s, started hearing about discoveries in autism, particularly by Simon Baron-Cohen, who had moved to Cambridge by that time, who was talking a lot about theory of mind. So we heard earlier about, some of the discrediting of the concept that, autism is due to a theory of mind deficit. But in the 90s, this was a big thing. There were lots of studies of theory of mind, leading on to investigations of empathy, and theory of mind has also been called mind reading. So the first papers on this were in the 80s, but it really emerged as a sort of big research theme in the 90s. So that was the same time that we were seeing people with FTD, and we thought, well, actually, we didn't know much about autism, but hearing talks on autism, they sound like people with FTD. So I wonder whether these theory of mind and social cognitive abilities break down in FTD. So that's what led us to start looking at theory of mind abilities in FTD. So we started with the core tests that had been used in autism research, like the Sally-Ann test that we saw an illustration of earlier. So we used that. But one of the ones I like to illustrate is the faux pas test. I'm always making these sort of errors, but then my family tell me I've got quite a lot of autistic traits, which is rather ironic given my research interests. But in this task, subjects are read stories like this. Jeanette bought her friend Anne a crystal bowl as a wedding gift. Anne had a big wedding, there were lots of presents. A year later, Jeanette came over one night to Anne's for dinner. Jeanette dropped a wine bottle on the crystal bowl and it shattered. I'm really sorry, I've broken the bowl, said Jeanette. Oh, don't worry, said Anne, I never liked it anyway. Somebody gave it to me for my wedding. So, you know, did somebody, was there a social faux pas here? And they answer various questions about it. And we showed that patients with FTD were very bad at this task. And we used the classic reading the eyes in the mind. And we used cartoon tests. And this whole lot of theory of mind sort of tasks showed deficits in FTD patients. There was also a very nice test that I thought I'd include because it was part of the research that Chris Kipps did a few years later using this test. I'm not sure how many people know about it. It's called the TACIT. And Skye MacDonald in Sydney actually invented it for use in traumatic brain injury subjects. And so there are these taped social vignettes, and some of them have a very sarcastic tone of voice and others don't. So there are things like a couple talking to each other, and you see the video of it, and one of them says, oh, you know, shall we go and visit my sister in the Blue Mountains, or, you know, this weekend? And the husband says, oh, well, you know how much I love your sister. That'd be just great. You know, I can't think of anything better to do. And that sort of thing can be put across in a sarcastic or a non-sarcastic way. And sure enough, we found huge problems in the FTD patients doing this task. And so gradually, through studies of theory of mind, but also emotion perceptions. I wasn't going to show you the data, but people with FTD have problems judging emotion from faces, from voices, from music. I've shown you some theory of mind, some sarcasm assessment tasks show problems. And in various studies, we showed that performance on these tests correlates with pathology in the orbitofrontal insular system. But of course, we're interested today in autistic spectrum disorder. And of course, many of these things, well, I won't call them deficits, these findings have been found in autistic spectrum disorder as well. I don't know what we're meant to call mild autistic spectrum disorder now. So I've put Asperger's in small letters up there. But, you know, we've heard about the criteria for autistic spectrum disorder, which involve impaired social interaction, difficulty with social reciprocity, repetitive and stereotype patterns of behavior interfering with social and occupational life. Okay, so the story so far is that we've got patients with behavioural variant FTD, and they've got all these symptoms, and their brains show atrophy, and they progress. But they show a lot of the same social cognitive deficits as ASD, but it seemed fairly straightforward to separate the two. I'm going to now introduce what we've called phenocopy syndrome. And we became aware in, 10 years into running the clinic, perhaps, in Cambridge, about the year 2000, that we had two populations of patients. So these are two cases coming to the clinic, both with the same symptom profile, both scoring highly. The the CBI is a Cambridge behavioural inventory that was designed to give to families to fill in, that has sections to pick up all the core symptomatology of FTD, as well as symptomatology more characteristic of Alzheimer's and other disorders as well. But the score of 70 is very high. So both these patients have very high scores on the CBI. Both were performing normally on general cognitive screening tasks. That's not unusual in early FTD. But in one case, they went downhill rapidly over 2 or 3 years, leading to a nursing home and dying with pathology. In the other case, keep coming to the clinic year after year. And in fact, these studies, it's a little known secret, known to people who did research in Cambridge, but actually those studies that we did all the theory of mind and things, those early studies of FTD, were rather enriched with these patients because they were willing research participants and they came to the clinic every year, whereas the people with what you might call real FTD were dying out quicker than we could replace them. So we had these patients who we thought after a few years, well, they'll deteriorate, it's just slowly progressive, but they didn't. And in these studies were done by Rees, who I'm delighted is here today. This is what he used to look like in Cambridge days. And we developed these visual rating scales of MRI, and we showed that there were 2 groups of patients. The true behavioural variant cases had or developed brain atrophy, and the patients who had brain atrophy went down here like this, and within 10 years they were all dead. The people with non-progressive, so in the beginning we didn't know what to call this, you know, we were calling it slowly progressive or non-progressive. So in the beginning, we called this non-progressive bvFTD, absolutely normal scan, kind of carrying on, not dying. And then Chris did some studies as well when we had PET imaging became available to us, and we thought, well, they're not showing changes on MRI, but MRI is not very sensitive. Maybe they'll have changes on FDG PET, which is a much more sensitive index of synaptic function and things. And so we did a series of PET scans, and those with normal MRI also had beautifully normal PET scans, whereas those with abnormal MRIs had even worse looking PET imaging. So these non-progressive cases, we became more confident that they didn't have FTD and started using this term phenocopy, because they looked as if they had FTD to begin with, but were not progressing over time. And this is just another study that showed that the ACE separated out the groups a little bit in the beginning, but over time, those with abnormal imaging were going downhill. Those with normal imaging were staying up in the normal range. So it was about this time that I moved to Sydney, and you can see the effects here on Michael Hornberger. So Michael worked in Cambridge, and he and Ada, his wife, moved to Sydney with me. And to begin with, we didn't have that many patients in Sydney, but we collaborated with the people in Cambridge because we got 15, 17 years of data from Cambridge. So we carried on producing things based on Cambridge data. So we thought, well, there must be some difference that we've missed between the symptoms in the phenocopy and the real cases. Let's examine all the clinical features that we can think of. Maybe there are some things that separate out the two. At least in this study, we didn't find that. We found that the phenocopy and the non-phenocopy cases looked very similar. I'll return to this, that we may, I think this is perhaps worth looking at again. This is the research team, how it began with myself and Olivier Piguet, who was my sort of principal collaborator in Sydney over the last 15 years. When we were looking at, well, what really, can we pick out these phenocopy cases early on? Paradoxically, one of the things that we found separated them out was memory performance. But of course, it's said that memory is the marker of Alzheimer's disease and that memory is relatively normal in FTD. That became enshrined. I think it was even in the early Manchester criteria about memory being normal. But we certainly found that even at presentation, those that progressed had poor memory, in some cases as bad or nearly as bad as Alzheimer's. I thought I'd mention, I wanted to mention Ineda Miyoshi, who was an occupational therapist who did a lot of work with us in Cambridge. And there was one really interesting study that she did that I was reminded of when putting this together. So Ineda, being an OT, was very interested in everyday practical performance on tasks. And these patients coming to the clinic, the relatives, the wives usually would say, oh, you know, he can't load the dishwasher, he can't make a sandwich, you know, doesn't do any housework, you know, doesn't change his clothes, you know, I couldn't leave him to make his own breakfast even. Same as the FTD patients. But Ineda visited the homes of these patients and she got them doing these tasks for her and scored them up, or had other people score up videoing of, you know, preparing a lunchbox, of, you know, stacking a dishwasher, you know, various practical tasks. And the phenocopy cases were much superior at these ADLs when she actually tested them at home, which was just a little interesting snippet I thought I'd include. So, you know, that led us to pondering a lot over the years, lots of discussions with Chris and Reese when and Boyd when we were working together, saying, well, what is this phenocopy syndrome? Maybe, you know, some of them do have degenerative diseases that, you know, we just can't pick up. Their MR's normal, their PET's normal, but, you know, maybe they've got something brewing in the brain. We don't know what it is. There's very limited pathology, but 2 Cambridge cases have died for other reasons. One man had a massive DVT in a pulmonary embolus and died, and we had his brain. Can't remember the other one, cancer maybe. But we had brain donations from 2 phenocopy cases and they were normal. Although there is another report, I think from San Francisco, of 1 or 2 cases claiming there is pathology in these people. So, you know, have some of them got a very slowly neurodegenerative, so have some of these patients got undiagnosed ASD? You know, I'm slipping into anecdote land here, but it's certainly the case that we had people in Cambridge who we had diagnosed with FTD, and they came along with their wife, and the wife reported all these symptoms. And then we were getting more interested in phenocopy syndrome. And as we looked at this person more carefully, you know, their wife reported these symptoms. And then we said, well, how long have you known your husband? And they had only been married like a year or 2 before these symptoms presented. How did you meet? Oh, we met online. Oh, we went for a few dates. You know, then they got married. And when we got to see the brother of this patient who managed to come into the clinic and talk to the brother. And the brother said, oh, he's always been like that. He never liked to change his clothes, and he'd eat out-of-date yogurt and spent all his time pottering around old motorbikes in the garage and never interested in people. And, he never had any friends. So it was clear that at least some of these patients had undiagnosed lifelong ASD, that life circumstances and change of wife had, brought them to the clinic. The group in the Netherlands have also been interested in the sort of phenocopy, difficulty distinguishing early bvFTD in the clinic, have reported more a range of other psychiatric syndromes of undiagnosed bipolar disorder, of lots of conflictual relationship problems in these patients. Who do we recognize this person? Jung, very good. Carl Jung, sitting by the lake, contemplating life. Of course, Carl Jung was very interested in changes in later life, kind of involutional changes and changes in personality that occur in later life. And, being married to a psychotherapist, a late life psychotherapist, has made me sort of ponder some of these issues about, looking at the personality and social setup of these patients. So, part 4. So, phenocopy syndrome, becoming quite confident that, a lot of these patients don't have FTD, and, maybe some of them have Asperger's. There's been autism that's been non-diagnosed earlier. But then along comes the C9 ORF gene. Just a little bit of background for those who are not so intimately involved with FTD research. So we have known for a long time that up to 30% of people with FTD have a positive family history, and that across the spectrum of different sorts of FTD, it's very much those with bvFTD rather than the progressive aphasias. So all the positivity comes from the BV cases, and the smaller subgroup who have FTD in association with motor neuron disease. So those are the two very genetic forms of FTD. Now I've put the fonts in sort of important. You don't even need to read these two because they're so unimportant, so rare in FTD. And until 2011, I think it was, that we knew there was a lot of familial FTD. These various genes have been discovered, notably the progranulin and the tau gene, but they only accounted for a small proportion of the familial cases. The majority, we didn't know what the causative gene was. But then in 2011, two groups simultaneously described this mutation, which were very large repeat sequences on the C9 chromosome in familial FTD and motor neuron disease. And if you take people who develop FTD and motor neuron disease, about 50% of them have this gene mutation. If you take people with bvFTD with some kind of family history, it's about a third. And even in sporadic cases, you find a small proportion. And what emerged as we and other people started sort of reporting the patient, everybody sort of screened their populations for this C9 gene, and a number of people found that there was a lot of psychosis in the FTD patients, and this can precede the onset of dementia by a decade, that the MRI may be fairly normal, and then sort of quantitative MRI studies have shown that there's more thalamic and cerebellar involvement in the C9 cases, so they don't show a lot of cortical involvement relatively, and it can be slowly progressive. So we had a couple of, so that suddenly made us think. So this is Emma Devaney, who did a lot of work in Sydney in the C9 and in the sort of neuropsychiatry of FTD. We suddenly thought, well, maybe some of our phenocopy cases are harboring the C9 gene, and that they've got unbeknown to us. So this is a study we did in Sydney, and we took people who had 3 years of follow-up but had not progressed at all in those 3 years, and we screened them for the C9 and the other genes, and they were all negative. And that contrasts with 11 people that we'd seen who progressed, and we found that this was a bit unusual as the numbers grew, but in this cohort, a high proportion of the progressors did have this C9 mutation. So that was reassuring that we weren't missing C9 mutation, and that didn't account for a lot of phenocopy cases. But obviously, I was interested. We'd had all those patients in Cambridge, and I knew that James Rowe had continued following up a lot of our old cases. And so eventually, after all the complexities of ethical approval and retrieving their DNA, because we took blood from all these cases, we did manage to get 16 of the people who'd had bvFTD, normal brain imaging, at least 5 years of follow-up. In fact, 10 of them have been followed up for more than 10 years. And we found one positive case. So it depends how you sort of interpret that. So occasional cases of the phenocopy syndrome are due to this gene mutation, but it doesn't seem to account for the majority. It would be our take on that. Now, as we started to accumulate more C9 cases in Sydney, we noticed what other people have been noticing is that we had these really interesting families. So this is one family, if you look at the color coding here, blue is motor neuron disease. So this is a family with predominantly motor neuron disease, but one with FTD, and an elderly relative who'd had schizophrenia. This is another family with another MND case here, a lot of psychiatry, and a grandchild of this person with motor neuron disease had been diagnosed with Asperger's. And as we started asking more about Asperger's in the clinic, people kept saying, oh yes, you know, my grandson or my nephew or somebody has been diagnosed with that. So we decided to look at this systematically. So Emma did this monumental study that involved interviewing and giving psychiatric inventories to 1,400 family members, first and second degree relatives of 29 C9 positive cases, 60 negative cases. This shows the data for a family member who has been diagnosed with autism, typically as children presenting, being diagnosed with autism. And you can see that the percentage is enormously higher in the C9 than in the positive than in the negative, a relative risk of about 4 or 5. And this is the findings for other psychiatric syndromes in the family. So there's a lot of psychosis and schizophrenia compared to bipolar disorder, slightly increased risk of suicide. And this has been confirmed in a couple of other studies. This is a very large group from Ireland led by Orla Hardiman, who's done a lot of work on genetics in more focusing on motor neuron disease, because she's a motor neuron disease neurologist. But again, finding this very high rate of autism in the families of the C9 cases and of schizophrenia. So that leads one to think, well, how common is the mutation in populations with schizophrenia and autism? There have been some studies in schizophrenia. This was a very large database in America where they screened for the C9 in a schizophrenia population and found just 4% were positive. I haven't found any studies where a group of autistic spectrum children or adults have been screened for the mutation. So some of the kind of issues and things that I've raised to think about in our panel are listed here. So it's become a very complex intermeshing of sort of FTD and ASD. So these are some of the sort of issues. Is the phenocopy syndrome simply ASD presenting in later life? Well, I think it is in some instances, but I think the phenocopy syndrome is actually a sort of final common pathway of a number of problems, and it's not going to be all just people with ASD presenting in later life, but that accounts for some of them. What happens to people with ASD as they age? Do their symptoms, which kind of resemble FTD, get worse? And what's the effect of brain aging on top of ASD? That's part of what Emma is currently trying to do in between having children in Australia and collaborating with groups internationally to try and look at that. Could ASD actually be a risk factor for bvFTD? Maybe that neurodevelopmental abnormality kind of sets the scene for developing FTD later in life. What are really the key, are there some key differences between ASD and FTD? We did a lot of research, which I haven't gone into at all here, about appetite control and food preferencing in FTD, which seems to be fundamental. And we did this sort of breakfast test and various things. And I wonder whether the food preference thing is, could be one of the key distinctions. But maybe there are others. And again, Emma's looking at this. FTD, psychosis, and ASD appear to co-occur in families with this gene mutation. And is this gene mutation a significant contributor or not to ASD? Nobody's looked yet, as far as I'm aware, of screening a bigger autism population for this gene, so we don't know. So this is the gang just pre-COVID in Sydney. All the sort of collaborators that have been working with me on psychology, genetics, pathology, and various aspects of FTD. And I didn't have the scope to, mention work by even a fraction of these people today. So I'll stop there. I think I've finished in time so we can have the panel discussion. So thanks very much.
So before we will get the panel down and be seated, but before we do that, I just wanted to present a gift to Professor Hodges for his Lifetime Achievement Award from the BMPA. I should say that many of your previous sons of research, so the people who've trained under you, are here today, largely because I emailed them all.
I thought that was a bit odd that there are so many.
Yes, well, there you go. And I used one of your previous colleagues, Adam Zeman, because your shirt today is rather muted.
Oh, it is a bit muted.
And so there is a particularly lovely shirt here.
Oh, yes.
That Adam and various other people have worked hard to try and find for you.
Oh,
as well as a book of some anatomy stuff that we thought.
Lovely.
But the Lifetime Achievement Award as well. Obviously, this piece of crystal will, I'm sure, take pride of place. There you go. See?
Oh, Cahal and the Story of the Neuron. Lovely. Okay, great. Thank you very much. Thanks, George.